So good morning, guys. So yesterday we were dealing with the genitourinary anatomies and physiologies. So today we'll deal with the disease conditions, right? Hope this is visible for you. The genitourinary disorders. So today we are going to see the genitourinary disorders. Kindly check these systems are important. All the vital organ systems are important, like cardiovascular system, respiratory system, and neurology, as well as the gastroenterology, the genitourinary. All these five systems are very important. You may get a lot of questions from these systems. Okay, so today we shall see what are the disease conditions in the genitourinary system. The first condition. See, all the assessment part, as all the assessment part in the genitourinary system will be dealt in the disease condition itself, and the medicines that also will be discussed here. Okay, the other portions we have discussed yesterday. Now, the major thing is urinary tract infection in the genitourinary system. Okay, what are the urinary tract in diseases? What bacteria that causes the urinary tract infection? Okay, you can study like this keeps. Okay, keeps. This is the mnemonics for the bacteria keeps. Klebsiella, Enterococcus, Pseudomonas, Staphylococcus aureus, and it may be an enterobacteria, that is E. Okay. So Klebsiella, Enterococcus, Enterobacteria, then Pseudomonas, Proteus may be the and Staphylococcus. Okay. Then the main thing that causing the urinary tract infection is Escherichia coli. Okay. Escherichia coli, E. coli. Then the ranking of that, it is Escherichia coli, Klebsiella, Pseudomonas aeruginosa, okay, and Proteus. So this is the ranking of that. The main causative organism is Escherichia coli. Then comes the Klebsiella. Then comes the Pseudomonas and the Proteus. Okay. Staphylococcus is the least one, even though it is causing the urinary tract infection. Okay. For the urinary tract infection, you have to understand that the main causative organism for the urinary tract infection. Main thing is the Escherichia coli. Okay, then comes the Klebsiella, Proteus, Pseudomonas, and your Proteus. Fine. Now, what will be the signs and symptoms? The main signs and symptoms of the urinary tract infection. Urine color will be changed. It will be dark. Okay. Then blood will be present in the urine. Pain in your pelvis. Okay. Burning sensation when you're urinating, you may have a burning sensation. The urine may have a strong odor. Then urgency to urinate. Urgency in the micturition. That is another main symptom of this urinary tract infection. Hope the sorry. Hope this thing is clear with you. So the main disease condition is a urinary tract infection in the urinary system. And what are the signs and symptoms? The main symptoms that the presenting complaints of the patient will be lower abdominal pain. First thing is there will be a lower abdominal pain. There will be pain in the pelvis area. Burning sensation will be there, and cloudy or a dark skin. You will be having RBCs and urgency to micturition. That is the main management. Then, this is what we have studied in the previous classes, like what are the changes in the color of the urine. But see, there are some another things which you have to check in the urination or in the color of the urine. First one is a clear yellow urine. Clear to yellow urine, which urine is the normal, or you are actually properly hydrated. Next, a cloudy presence of the urine. Have you seen a cloudy presentation of the urine? It may cause in case of urinary tract infection. Okay. And one more thing, there is a white color urine. Okay. A white color urine. Urine will be white, which is known as chyluria. Okay. White colored urine. This is known as chyluria. It can be mainly seen in filariasis. Okay. White colored urine is chyluria, which is seen in filariasis. This is once asked. This question is once asked. White colored urine, which is known as a chyluria. It is present in filariasis. Next is red or the pink color, which is the sign of blood. Hematuria. See, stone may be a reason, infection may be a reason, or any bleeding disorder that is affecting the kidney, ureter, urinary bladder, urethra. Okay, in any area, if there is a bleeding, yeah, somebody have joined just a minute. So in that condition, anything may leads to anything may leads to this condition. Okay, no, then it may be a cancer also. This red or pink color, it may be a cancer also. Mhm. Dark orange. Dark orange can be a sign of dehydration. And we have already said the dark orange is a complication or it's a side effect of a TB medicine. I hope you remember the name of the TB medicine, which is that medicine that is causing urine discoloration to orange. Who's that joining again? Okay, so that's about the orange color. Next is the green color. See, identify this one. Pseudomonas. The bacteria Pseudomonas may change the color of the urine to green. Okay. Then brown color. Any kidney disorder or as a sign of muscle injury or a breakdown in extreme conditions. Okay. Extreme exercises. That's a brown color. Next, blue. Blue can be a rare genetic disorder and benign hypercalcemias. Okay. In any hypercalcemias, the urine can be in blue color. So usually these brown, blue, green, they won't ask for these exams because these are a bit more for the prometric exams. They'll usually ask what is chyluria is, red or pink colors, orange color, and the yellow color. But you must understand there are other colors, green in case of pseudomonas infection. Kindly study from the class itself. Green in case of pseudomonas infection, brown in case of extreme exercises due to muscle breakdown, and blue color due to benign calcemias. Now, signs and symptoms, how you prevent that? We have already said you will be having a strong urgency for urination. Hematuria will be the strong smelling in the urine will be the sensation, urinary burning sensation will be the pain. You will be having a lower abdominal as well as lower back pain. Pain over your bladder region, that is your lower abdominal pain, muscle ache, nausea and vomiting. See, in case of urinary tract infection, the patient may have the nausea and vomiting. Fever. Since it's an infection, you'll be having fever. So fatigue is all associated with the disease condition. In every disease condition, you may feel like fatigueness. So it's not the main symptom. How you can classify the patient whether the patient is having any whether the patient is having any urinary tract infection. The presenting complaint of the patient approaches you with these conditions, like patient will be having low abdominal pain or a back pain, patient will be having a urinary maturation. So then we'll ask the histories of whether how what is the amount of fluid that you intake usually. Usually in that condition, the amount of fluid intake will be less. Okay. Or if the patient is pregnant, usually in pregnancy, urinary tract infections also may affect. And how will you prevent it? See, simply drinking water. Adequate hydration is the best choice to prevent the urinary tract infection. Then don't control the urine because see, in some conditions there won't be this urinary tract infection. This mainly affects the females because they have a tendency to control the urine if they are not getting a proper washroom. They'll control the urine, and in India we can see that the incidence of urinary tract infection is more in case of females when compared to male. Then another is an anatomical incidence also. The urethral length, the length of the urethra is quite short in case of females, whereas in case of male it is long. Yeah, this also predisposes the condition that the urinary tract infection is mainly occurring into the females. Okay, then proper washing after urination. The urethra and the urinary meatus has to be washed after urinating. Thus, you can prevent the urinary tract infection. And see how to wipe. It should be wiped from front to back so that no fecal sediments is coming into the urethra when when you wash it from back to front. Okay, it should be always uh, wiped from front to back. And you have to avoid douches or feminine hygiene sprays. Okay, you in case of urinary tract infection. See, if there is a urinary tract infection, a female is not supposed to use these what the cup which they are using for menstrual period, the menstrual cups. It should be avoided because it again increases the chance of urinary tract infection. Then what you have to promote circulation, loose dressings, and undergarment should be cotton. So these are very specifically for the females because they are very prone for infections. Okay. And how will we check? How will we confirm it if it is a urinary tract infection? See, simple and urine analysis will say that when you do your routine urine examination, you can find that there is an infection in the urinary meatus. So the pus cells will be increased. Normally, pus cells should be zero, epithelial cells should be zero in the urine. But in case of UTI, the pus cells will be increased, the epithelial cells will also be increased. So what you have to do in that condition? You have to keep the you if the pus cells are more, we'll go for a urine culture so that we can properly identify the bacteria and we can do we can correctly prescribe the medicine. So till then, what will you do is that cephalosporin groups is a drug of choice. Okay, cefixime. Usually we start with the tab cefixime. For if it is an injection, we'll go for ceftriaxone injection. So tab cefixime 200 mg BD is the dose. Then tab injection zone 1 gram BD is the dose. So that is the management of urinary tract infection. Then OTC dipsticks will help you to understand that urine culture. So further testing. See if the patient is having a repeated urinary tract, we'll treat the patient. We'll send that patient back again after 1 week. The patient is coming with the same complaint. We are treating the patient. All the preventive methods have been given to the patient. The patient is also taking care of that. Even after that, the patient is getting the urinary transfer. Then we can find that there is some problem with the any other area. In that condition, we have to do a cystoscopy. What is cystoscopy? Just a catheter is being passed through your urethra to identify if there is any problem in the urinary bladder, so that if any uh, anatomical structural abnormalities are there and so on, then we'll go with the ultrasound. Why an ultrasound? To identify whether the kidneys are normal, whether the kidneys are getting more infected, or if there is any anatomical disturbances like horseshoe kidneys, or if the kidneys are damaged, or the structural abnormalities. If there's any structural abnormalities, as I had said, in the case of horseshoe kidneys and any other diseases that may prevail into the condition of the urinary tract infections. Then CT or an MRI, it's not for the urinary tract infection. Okay, we are not going to do the CT or MRI for the urinary tract infection. But if the patient is getting repeatedly urinary tract infection, we have to understand. We have to check what is the reason for these urinary tract infections, right? For that, we have to check the CT of the kidney so that if there is any other underlying problems which is related to urinary tract infection, or if we are not able to understand what is the problem with the or what is the cause of these urinary tract infections. Now, antibiotics I have said first drug of choice will be always the cefixime. The nitrofurantoin is a drug of choice. Nitras, you might be very familiar with all those things. So nitras will be 10 mg twice daily. So that is the management. So there is no surgery for the urinary tract infection. Yeah, if it may leads to any complications, then the condition is different. Then the urinary tract is not the main problem. Okay. Sorry. Uh, Pains or next condition is urolithiasis or oh God. Urolithiasis or stone. Okay, stone in the kidney. See the renal pelvises. You can see in the renal pelvis there are a lot of stones. So what we'll check one by one. What is the difference between urolithiasis and nephrolithiasis? The nephrolithiasis means nephro means kidney, uro means apart from kidney, like the parts of your ureters, urinary bladder, and ureters. All these things comes under the urology condition. So when if there is any stone present in these portions like ureter, urinary bladder, we'll call it as urolithiasis. The other part, which is when the stone is in the kidney, we'll call it as nephrolithiasis. Okay. Now, that is urolithiasis and the basic difference between urolithiasis and nephrolithiasis. Now, what is the pain? What is the main signs and symptom? The main signs and symptom includes pain. So the pain may be varying. Okay, pain may be varying. Just a minute. Huh. So there will be pain. Yes, just a minute. Just a minute. Just a minute, guys. Sorry. Yeah. So the urolithiasis and nephrolithiasis, the main signs and symptoms is pain. Okay. So the pain you have to check for the what you must have a proper clarity about the pain from where the pain starts. Okay. The pain might be a radiating pain. Okay. So usually in case of lower urethral pain, which if the stone is in the urethra, you will be having pain in your penis. Okay, usually in case of females, urethral stones are quite impossible to see because of the shorter urethral pain, shorter urethra. Then in case of males, when there is a urethral stone, it can lead to a pain in the penis. The pain will also be there in the groin and also into the scrotum, the scrotal area, the penile area, as well as the groin area will be having pain. Okay. Then ureters, if the stone is in the ureters, your symphysis pubis pain will be mo- near your symphysis pubis, and if the stone is there in the kidneys, if it is a nephrolithiasis, you can have a stone on your lower back. Okay, so the characteristics of pain may be different according to the presence of stone in the different parts of the urinary system. Okay, so and since there is a stone, it may cause bleeding also. So hemorrhage will be there. When there is hemorrhage, there is a lot of chance to get the infections. Okay, then renal colic or the renal pain will be which the characteristics of the pain. It will be dull. It will be an aching pain. There will be a sudden or a sharp, severe pain. Okay, the pain may be radiating towards the testicles in case of males, and in case of female, it may be radiating towards the bladder. Okay. Now, urethral colic may be radiating to genital. That's what I have just said now. Urethral pain, the urethral stones may be radiating towards your genitalia and your inner thighs. Okay. In case of these stones, there will be nausea, vomiting. Why pallor? Because of hemorrhage. There will be a bleeding, more bleeding through these urine. Diaphoresis. I have explained what is diaphoresis is. Right. It is excessive perspiration. Patient may be cool, the moist skin because of the diaphoresis. Okay. Because of the diaphoresis, the skin may be moist and cool. In altering urinary frequency. Okay, there is in some condition it will be retention, in some condition there will be urgency will be more. Okay. And apart from that, if there is in case of if stone is there, definitely there will be urinary tract infection also. So the signs of the urinary tract infections as well. Now, types of the kidney stone. We have cystine stone, calcium stones, uric acid stones, and struvate stones. See, what is of us previously what we were doing is that, see, usually we'll there was a water therapy for this. First, what will we do is that we'll scan the patient and we'll identify what is the size of the urine and where it is present. Usually, the size when it is less than 4 mm, water therapy will be enough. So, what we do is that we'll just give 2 or 3 pints of uh, this NS normal saline to the patient. We'll just fast rush the fluid fast and we'll give 40 lasix. So with the pressure of the with the pressure of the fluid, if there is any stone which is present in these areas, it will be washed out. When the stone is washed out, we'll say the patient to filter the urine so that we can identify the stone. So when they get a stone, that stone is given for examination and to identify what stone it is made of, whether it is a steam stone, calcium stone, struvite stone, or a uric acid stone. Okay, so in that condition, if we identify the stone, okay, if we identify the stone, then we'll understand that okay, this is the matter with the stone, right? So if it is a struvite stone, we have to avoid such kind of medicines. If it is a calcium stone, which we have to avoid the calcium forming foods. Okay, some medicines like are tomato. The tomato will cause a struvate stone. Oxalate stones are there. Okay, so we'll identify like that. But nowadays we are not preferring these hydrotherapies. Why? Because there is a chance of nephro, the hydronephrosis. The kidney may also swell with the fluid which we are giving. Since there is a higher chance of hydronephrosis, we are not preferring that. In medically, we are not preferring, but yeah, in some conditions, hospitals have been preferring that. Okay, the calcium stones are the 80% of the stones. So what are the risk factors? Vitamin D, dietary supplements, food very high in oxalates, avocados, dates. Just kindly take the screenshot. This there will be a question from this. If the examiner want to ask, the question will be like this. If a nurse identify the patient with calcium stone, what should be focused on these food? We have proper weightage for nutrition. Okay, the calcium, the vitamin D supplements you have to check. The avocados, dates, orange, raspberries, spinach, tomato sauce. Okay, because of the oxalate. Okay, now struvite stones. So struvite stones are composed of magnesium, ammonia, and phosphate. So why there is a struvite stone? If the patient is having a urinary tract infection, it is not for the one stand. Okay, if repeatedly the patient is having a urinary tract infection, there is a high chance of developing struvite stone for the patient. Okay, Klebsiella, enterobacteria, all these things, protease, and all those things. Next is uric acid. In case of gout, rheumatoid arthritis, okay, there will be uric acid stone. What is the normal uric acid level? It is 6 to 8. Okay. Next is cystine stone, which is just a 1%. Okay. Rare disorder called of cystinuria. Okay. Now, staghorn stone. The point that you have to staghorn means it is like the horn of a reindeer. It will be very painful stone. Okay. This the shape. The shape will be so disturbing. It will be like horns, which resembles the horn of a stag. The stag is a reindeer. Okay. That stone will be so irregular in shape, so that if it is present in any portion, it may it may cause a hell a lot of pain for these patients, and also there will be heavy bleeding. Okay, that is stag horn calculus. Like, what are the medical management? See, uh, all these things are symptomatic management. Okay, we don't have a proper management for that. It's just a symptomatic management. This is a surgical condition. Nephrolithiasis and urolithiasis is a surgical condition. So for the pain, we'll give opioid analgesics. Antibiotics will be given if there is a urinary tract infection. Then diet, we have to check the diet. That is the main. Pharmacological management, this is what we have said. Thiazide diuretics can be given. Alkaline treatment, and for this allopurinol and other symptomatic managements can be given. Okay. The antibiotic regimen for the that's what I have said. No, these antibiotic regimen won't be asked. I just want to understand. You just want to understand. Cephalosporin groups are the first drug of choice, and second is nitrofurantoin. Okay. So surgical therapies. What is the surgical therapy that you will give you? It is extracorporeal shock wave lithotripsy. Okay. It is ECSOL. Extracorporeal shock wave lithotripsy. When the stones and the sizes are more, if it is 20 mm or more or 2 centimeters of more, ureteroscopy. Okay, ureteroscopy when the stone is in the urethral areas. Okay, then we can just insert an cystoscopy as well as a ureteroscopy and we can remove it. Next, percutaneous removal or lithotripsy. Okay, we'll just make an outside opening and we can remove that. Like, see, extracorporeal shockwave lithotripsy. We'll just, what will you do? We'll just break the stone apart by applying shock waves. Okay, this is a painful condition so that the patient will be under sedation. Like, what are the complications? These may also ask for your question. Okay, what are the complications of extracorporeal shockwave lithotripsy? There will be sepsis. It can lead to hematuria. Okay, hematoma might be there. Then transient renal dysfunction may occur. Obstruction of the see the fragments of the stone can increase the pain also. Okay. See, we are just breaking the larger stone into smaller pieces. There are high chances that these smaller pieces may go and dislodge in some areas. So that the in order to prevent that, the extracorporeal shockwave lithotripsy will emphasize and focus on what breaking the stone into even very smaller pieces, which is less than 2 mm or 3 mm. Okay. Now, the cystoscopy, how the cystoscopy are done. So, in the cystoscopy, it is inserted through the urethra and we'll check in the urinary bladder. Okay, that is the cystoscopy. What we is like ureteroscope. See, if it is in the lower tracts, okay, if it is in the lower tracts, we'll just take a cystoscope and a basket instrument. See, you can see the picture how the ureteroscope is taking out the kidney stone. Okay, see, these are the varieties of uh, baskets. Don't need to understand all those things. Next condition, the renal failure. Okay, next is the renal failure. What are the types of renal failure? See, majority of the questions come from this area. Okay, the renal failures. There are two types of renal failures, my dear. Acute renal failure and chronic renal failure. So, what is acute renal failure? Acute renal failure means, as the name itself indicates, it's a sudden loss of renal function. Okay, there is a sudden loss in case of acute renal failure. There will be a sudden loss of kidney function. Okay, and the glomerular filtration rate falls in a short time. Okay, that is acute renal failure. And what is chronic renal failure? It is a persistent, chronically. Acute renal failure can also lead to chronic renal failure. Okay, but the chronic renal failure is a persistent renal failure for more than 3 months. It's a progressive and a long-standing process. No, uh, the causes of acute kidney. See, the kidney injuries, whether it is a CRF or an ARF, there are three reasons. Basically, the reasons are divided into three. Okay, pre-renal condition, renal condition, and post-renal condition. So pre-renal mean anything which is coming apart from the kidneys. Okay, anything which is apart from the kidneys. The renal condition properly in the kidneys. Post-renal condition means the kidneys are over. Then comes the ureter, urinary bladder, all these things. So that are post-renal conditions. So these three areas are causing the renal failures or renal injuries. We shall see one by one. Pre-renal condition. Okay. So when there is a decreased oral intake, which means or loss of fluid, diarrhea, vomiting, in that condition, what happens? In that condition, what happens? If there is diarrhea, if there is vomiting, the fluid which is present in the body will be decreased. The heart pumps 5 liters of blood, right? And the kidney needs 1.2 liters of blood per minute. So if the kidney is not receiving that for a longer time period, for a shorter time period, the kidney will try to increase the blood pressure, right? Like the RAS mechanism, how we have said. But even after if the patient, if the kidney is not able to increase the blood pressure, then what happens? In that condition, the kidney will try to accommodate it, but if not possible, it may leads to kidney failure. Okay, so that is the case in the conditions like diarrhea and vomiting. No, sepsis can be there. Okay, it maybe leads to sepsis. It may leads to sepsis. No, the sepsis can be led to kidney renal failures. Sepsis, like if poisoning is there, in case of, for example, ARF, snake bite. Snake bite may leads to acute kidney failure. Okay, acute kidney failure can be leads to the sepsis as well as poisons. Then next, septic shocks. So disseminated intravascular coagulation. Kindly write it down. DIC, disseminated intravascular coagulation or the sepsis may lead to acute kidney failures. Hypercalcemia, if there is an increase in the calcium in the blood. Medication like AC inhibitor. I'm not saying that when you're taking an AC inhibitor, it will cause the kidney failure. But for a long-term usage, diuretics. What are diuretics? Like Lasix, furosemide. Then contrast studies. So contrast studies mean if we want to do a CECT, which means dye injected CT, if we want to do a dye injected CT, or in case of an angiogram, we have to push the dye. If the dye is causing any problem, okay, in some conditions, the dyes will affect the kidneys and the kidneys will be failed. Okay, so the dyes which we are using for the studies, NSAIDs, non-steroidal anti-inflammatory over-the-counter medicines, like paracetamol will be for the pain. If the patient is taking paracetamol with no control, in that condition, it may lead to kidney failures. Okay, and unnecessary use of antibiotics, heavy dose of antibiotics. Okay, then cardiac failure. Any case of cardiac failure, why? If there is cardiac failure, the heart won't be able to pump much fluid which is needed for the kidney, which may lead to a cardiac failure. Okay. Next condition is intrarenal causes. So all these things that you were talking about was the pre-renal causes. Next is intrarenal causes. The problem, the culprit is the kidneys itself. Okay. So it's the glomerular diseases, any pyelonephritis, any glomerulonephritis will leads to this condition. Then you can say what interstitial diseases, any nephritis or long chain nephropathy, thrombotic changes. Then renal cell carcinoma, cancers in the kidney. All these things can be lead to these kidney diseases. Okay. Third one is a post-renal condition. So post-renal condition means if there is any obstruction. So obstructive uropathy. What is the main cause of the obstructive uropathy? The main cause of the obstructive uropathy is a stone. Okay. Or if there is any anatomical changes and tumors in the urethra, urinary bladder, or renal calculi, fibrosis. All these things are post-renal causes. And one more which I would like to add is that BPH, benign prostate hyperplasia, in case of males. In some conditions, BPH can leads to what, kidney failures. Okay. See, you don't study it in the two ways. Just study that in case of chronic, in case of renal failure, we have pre-renal, renal, and post-renal conditions. Okay. So the more or less the disease, the pre-renal as well as renal and post-renal cases are same for acute renal failure and chronic renal failure. So don't confuse yourself with this. Previous thing was enough. But the main thing in case of acute renal failure is if there is any sudden cardiac arrest, it may lead to an acute renal failure. Okay. If there is burns, so all the things should be sudden. It may lead to acute renal failure. Then poisoning, snake bite, anaphylactic shock. Okay, all these things. Anything which is acute, sudden will lead to renal failure, acute renal failure. Other things are very progressive. Fine. Now, what is the difference between ARF and CRF? This you have to understand. See, the history of ARF will be sudden, whereas that of CRF is gradual. You can only see a gradual change in that. Okay. And what about the reversibility? Yes, ARF is reversible in case of the problem will not be with the kidneys. Okay, it's a short phase. It is for a short phase, like in case of poisoning, in case of burns, in case of other cardiac abnormalities, we can revert it. But CRF is irreversible. Once the process of CRF started, like diabetes mellitus, diabetic nephropathy, okay, all may leads to a CRF. It is irreversible. And what is the size of the kidney? In case of ARF, the size will be normal, but in case of CRF, it may be reduced. The size of the kidneys will be reduced. The urine volume, it may be from oliguria, for decreased amount of urine, to polyuria. But from CRF, once the urine decreases, what the amount of urine decreases, it will continue like that. The patient will be always oliguric. Okay. Then what about the HB level? See, in ARF, no problem with the HB level. There won't be anemia. But in case of CRF, there will be anemia. Why? Why? Because the erythropoietin, it is produced by the kidney. Okay, erythropoietin. It's a uh, blood cell colony forming substance. Okay. Cell colony forming substance is erythropoietin. So the kidneys won't produce this erythropoietin, thus it leads to decrease in the hemoglobin level. Okay. And lipid profile, ARF will be normal, whereas in case of CRF, TCD, this triglyceride level, LDL, HDL, VLDL, all will be increased. Okay. Lipid will be increased. Fine. Now, how will you examine this? Have examine the findings of acute renal failure. There will be dehydration. Obviously, there will be dehydration. Then oral ulceration, halitosis, bad breath, that is halitosis. Tongue necrosis will be there. Hypothermia, the abdominal pain will be there. Mental status, poor mentation will be mental status will be different. Tachypnea will be there. Then vomiting and diarrhea. That is the main signs of acute renal failure. Okay. Next is a chronic renal failure. It is an irreversible process. The main risk factors are diabetes, which may lead to diabetic nephropathy. Okay, high blood pressure will affect the kidneys. Then heart problems or stroke, because the heart have to pump the fluid to the kidneys. Then obesity, definitely a cause of kidney renal failure. Family history of CKDs, tobacco use, age 60 plus, all these things predisposes the kidney renal failures. Now, what are the physiological causes of the kidney renal failure? So, physiologically, it may be hypertension, diabetes, chronic urinary tract infection, congenital abnormalities, vascular diseases, and HIVs. Which is why we say it as physiological means it is out of kidney. Okay, it is a pre-renal causes. See, pathological means if it is present inside the kidney itself. Glomerulonephritis, pyelonephritis, interstitial nephritis, tumors in the kidney, transplant rejection, or congenital disease in the kidney itself. Okay. Now, 5 stages of kidney. Kindly know that in the stage 5, we have already explained this, the GFR, glomerular filtration rate. In the stage 1, the GFR is 90. Usually, it should be more than 90. Okay. If it is at 90, okay, or we can say it is stage 1. No, mild decrease in the function, moderate, slightly decrease in the function, moderate decrease, huge decrease. Okay, if the GFR is less than 15, the kidney have been started failing. Okay, you can compare the size. The size is decreasing. That's why we'll call it as the stage 4 kidney failure and stage 5 kidney failure. It is on the basis of GRF, glomerular rate of filtration, or GFR, glomerular filtration rate, whatever. The complications of kidney diseases, chronic kidney diseases, cardiovascular diseases will be the infection. Okay. And as a secondary condition, you can have hyperparathyroidism. Okay. There will be mineral bone diseases. Definitely there is anemia. Why? The kidneys function, the erythropoietic function will be affected. Fluid volume overload will be there. Okay. Then you may have a heart failure. Uh, toxicity. Why? Kidneys are the organs that excretes the waste from the body, right? Excretory organ. If the excretory organ is not working, all the things will be deposited in the blood itself. So it may lead to toxicity. Then cognitive decline. Why cognitive decline? Since the waste that is creatinine, which will be present as an ammonia in the blood, so the serum ammonia level increases, which will alter the sensorium. Okay, your brain function will be altered. Impaired physical ability. Like, see, if the kidneys are not working, how will be the person be able to do his physical abilities? There will be fluid retention. Edema will be there. Respiratory, the edema can be anywhere present. It may be a pedal edema. It may be a cerebral edema. It may be a pulmonary edema. Anything, any edema can be happen. Okay. Metabolic acidosis. The CKD patient will be in metabolic acidosis. Electrolyte imbalances because there is no balancing stages like water absorption, water reabsorption, secretion of sodium, potassium from the nephrons. No, nothing will be done. So there will be an electrolyte imbalance. Nutritional problem will be the malnutrition. ESRD, end stage renal disease. It may lead to ESRD, end stage renal diseases. So if the patient is in ESRD, dialysis is the option, or you have to go for kidney transplantation. So diet, dialysis, drug. That is what you have to do. Okay. See, check this one. Calcium. You have to prevent hypercalcemia. Or in case of dialysis patient, okay, in case of dialysis, this is the focus of that. See, in case of CKD, the patient may go for hypercalcemia. But when we are doing the dialysis, the patient may go for hypocalcemia. Why? The machine will take the calcium out. Okay. So how you can find out whether the patient on mechanical dialysis? When the patient is on dialysis, the patient is going for hypocalcemia. How you can identify? The main thing that you can identify is that the patient will have severe calf muscle pain. Okay. So in that point, we'll just stop the dialysis and we'll just massage the areas. We'll just rush some fluid to the patient so that it will decrease the calcium saturation. Okay. Next, parathormone. Parathyroid hormone will be more, 2 to 9 times more than the upper limit. So you know the difference between parathormone and calcitonin. Now, understand your dialysis, how the dialysis is taking place. So we have peritoneal dialysis and hemodialysis. What is peritoneal dialysis? The peritoneal cavity acts as a membrane. So it may take 6 hours to complete per dialysis, okay, the peritoneal dialysis. So a dialysate will be inserted into the peritoneal cavity and we'll wait for some time. After that, that same bag will be kept beneath or just below the peritoneal cavity so that all the waste are being excreted into that. Okay, this is a peritoneal. It's a home process. You can do it at your home. Next, hemodialysis. What is hemodialysis? We'll take blood. We'll make an AV fistula, atrioventricular fistula in your hand. So after making that fistula in the hand, we'll take the So it is to increase the size of the veins and the arteries, okay, so that the blood can be withdrawn. One one catheter will be used as an vein, and second will be used as an artery. So the codings are blue and red itself. So from the blue, we'll take out the blood, and it will be passed through this machine. Okay, dialysate fluid will be the we'll add heparin into that to prevent the blood clotting. Then the dialysate will do the function of the kidneys, and it is revert back to the body. Okay, that is hemodialysis. Now, acute indication of dialysis. It's AEIOU, acute indication of dialysis. Okay, simply first one is acidosis. Okay, if less than 7.1 acidosis, we'll go for the dialysis. Electrolyte imbalances, high hyperkalemia, 7.8, 8. When it is more than 8, 9, we'll go for dialysis. Like intoxications, like lithium intoxication, toxins, or you can say poisons, and all those conditions, we'll go for dialysis. Overload, if there is a congestive heart failure, heart is not able to pump it properly. That condition, we'll do the dialysis. Then uremia, when there is uric acid accumulation in the body. So that is AEIOU, acute indications of dialysis. Now, indications of peritoneal dialysis. It's a treatment of choice. Okay, any patient can opt for that. The patient who is unwilling to do the renal transplantation and unwilling to go with the hemodialysis, they can go with the peritoneal dialysis. Okay, and the main thing is the many older patient may be having risk because of the adverse effect of the heparin. Okay. Now, what are the contraindications of peritoneal dialysis? It is done in your abdomen cavity. If there is herniation, okay, if there is proper growing pain, colostomy, if there is an opening in your intestine itself, colostomy, it's a contraindication. Obesity, because the abdomen will be so full of fat so that it won't accommodate the peritoneal fluid. Okay, lung function, if there is a decrease in the lung function, why? If a fluid is given to your peritoneal cavity, your diaphragm will be pushed up so that you may have a breathing difficulty. Psychosis, why the patient won't be cooperating. Diverticulitis, changes in the urinary constructions. Now, what are the indications of hemodialysis? One is there will be fluid overload if the kidneys are not able to remove it. Hypertension, hyperkalemia, then what lethargic, any infections, severe infections, any what poisons conditions, pericarditis, bleeding from other parts, epistasis, metabolic acidosis, then what when you have your pulmonary edema. See, simply when there is fluid overload. Okay. And what are the fluid overload conditions that we are explaining here? Okay, fluid overload is the main indication of hemodialysis. Okay. Now, what are the advantages and disadvantages? So, no, see, leave that. No questions will be asked from me. Now, contraindications. Other chronic diseases. Hemorrhage, if the patient is having highly hemorrhagic, and hypertension, if the patient is very old to accommodate the dialysis, maybe just leave that person. And hypercoagulopathy, because we have to tamper with the heparin, so that if we take the patient's blood out of the body, there will be high chance of coagulopathy, so that even if we add heparin also, the blood may be clotted. So if the blood is clotted, we won't be able to resend the blood to the patient. Why? Because the clot, when once the clot is in the bloodstream, it may dislodge into any part of the area. Okay, so that we won't send back the clot to the patient. If there is a problem with the heparin, the entire blood which is taken out of the body will be which we have to shift it out, and the patient may go for anemia as well. Okay. And what are the nursing management in the hemodialysis? Vascular access. You have to check for the vascular access and fluid imbalances. If there is any fluid imbalances which is coming in the patient, IV cannula have to be checked. There should not be a leaking or bleeding from that. You have to continuously in every hour you have to check the BP of the patient who is undergoing the hemodialysis to check whether there is a fluctuation in the BP. If the BP is low, you have to stop the dialysis and increase the fluid. Okay. Then you have to check for the pain and the discomfort. If there is any infection to the patient, okay, then skin care should be done. Fine. So these are the nursing management. Then post dialysis care. See, pre and post those people who are who have worked in dialysis department will be very much familiar with all these steps. First, when the patient come, you have to check the BP, then you have to check the weight. BP is secondary. First is the weight. You have to check the weight, and according to the weight of the patient, we'll take the fluid. Okay. Suppose we have an ideally 70 kg what we have set, and the patient have gained a 2 liters. So that 2 liters is water. Okay. So you have to take the 2 liters from the patient. Fine. So on that basis, we'll set the amount of water that the dialysis machine should take upon. Fine. Then check the weight and compare that. What is the amount that is lost? What is the amount that is taken? Fine. Then medicines. The point is, in some conditions, the patients with with kidney failure due to the increased effect of hyperkalemia, we will stop some foods that the patient should not eat, like oranges and so on, which is having a high uh, this potassium level. So during dialysis, what will help the patient is that we say that if you are craving for any food items, you can take along with you to the dialysis room, so that when we just start the dialysis, usually the dialysis is for 4 hours, right? When we start the dialysis, the patient can have that food. Okay. Usually, if it is what, if it is this orange, the patient can have that. Okay. And surgical sites. So atrioventricular fistulas can be removed. So how these atrioventricular fistulas are placed? This is an artery. Okay. This is a corresponding vein. This is an artery and this is a vein. So what would be they'll anastomose this. So what is anastomosis? They'll just anastomose it like this, okay, like this, like this. Okay. This is called side to side anastomosis. Side to side, side, side to side anastomosis. Okay. There is another method known as the artery. Suppose this is the artery. A vein will be connected to this like this. This is known as end to end anastomosis. Sorry, end to side anastomosis. End to side anastomosis. End to side anastomosis. Next is end to end anastomosis. Artery will be taken like this. Vein will be taken like this, and via uh, anastomosing like this. So this is known as end to end anastomosis. Usually side to side anastomosis is done. So why we are doing this? If a radial area, if the radial arteries and veins are anastomosed like this, you can see here you can see the fistula. We'll grow the fistulas. Then these veins can be properly visible. So, okay, it has to accommodate the size 16 gauge needles. So for that purpose, we are growing the arteries and veins. Okay, so that there should not be any blockage in the flow. Usually, what happens in the you are nurses, you will be finding out that when we do an IV cannula, even with the 18 gauge needle, after some time it may get dislodged because of the floating factor which is present in the blood. But here we want uninterrupted flow of the blood for 4 hours, right? For that purpose, the arteries or the veins that we usually both we take is what is veins. Okay, no arteries involved in this artery. We are considering one vein as an artery. Okay, that is just a difference. We are considering a vein as an artery. Fine. Now, the fistula, AV fistulas have been created like this. So, radial artery, saphenous vein, medial cubital vein, basilic vein, these are all the areas which we can mingle these things. Okay. So, and now the catheter can be placed in other areas, like we can use the what inguinal catheter, that is a femoral catheters can be we can use jugular things can be done. The AV fistula is an option. Then permanent catheters can be kept inside the jugular veins. Okay, see like this permanent catheters. This is not a permanent catheter. This is a jugular vein. Okay, this is a permanent catheter. See, which is subcutaneously placed. Okay. And what are the AV fistula complications? It failed to mature. Stenosis will be the okay, stenosis, maturity failure, thrombosis, aneurysm, okay, heart failures. All these things are the main complications of the AV fistulas. Now, what are the pros and cons? There will be a risk in the this fistulas. There will be a rupture. Cosmetic problems will be there. The cosmetic benefits, which means if there is a catheter in your in your neck, it shows a simple weird appearance. Like so, if it is there in the hands, you can just use a full sleeve so that it won't be visible. Even if it is visible, it's just an like a blub, so that it won't be easily recognizable. Okay, so the chance for the rupture is also less. And what are the cons? Loss of access site. If it is not working, we lose it. Okay, post ligation hypertension can be there, and the cause, just leave the cause. No, source of shunt infection. If we are having with a problem with the fistulas, complication with the fistulas. Okay, if we are using the fistulas, injuries can be occur at these fistulas, and which may leads to bleeding. If it is improperly cannulated, it may also lead to bleeding. Improper disinfection, it may leads to hematoma. It may leads to thrombosis. It may leads to skin diseases. Okay, contamination of the puncture site, and again infection. What they are saying is infection. Okay, hematoma will be there. Thrombus will be there. There can be an aneurysm. Okay, so these are the complications of the fistulas. Okay, hematomas, thrombosis, aneurysm, injuries, bleeding, improper cannulation, disinfection, contamination at the puncture site, skin diseases like itching will be there. Okay, so these are the main complications of your this one. Fine. So guys, what is the status? Are you able to follow? So we were talking about the next condition is glomerulonephritis. Okay. So the glomerulonephritis is the inflammation of the glomerula or the glomeruli, the small blood vessels. Okay. Why it is happening? Okay. Due to any reason, any of the reason, the antigen will be produced or released into the circulation. When an antigen is released, there will be antibody formation. Okay, simply because of any condition like glomerulonephritis, maybe usually in case of any pathogen, inversion of any pathogens, like urinary tract infection may also be a reason. Any pathogen which is present in the glomerulus will produce or these bacteria can act as an antigen. When there is an antigen releases, it leads to the formation of antibodies. So when the antigen is released, the antibodies will also be released. Then the antigen antibody reaction, which leads to a complex in the glomerulus, which will initiate an inflammatory response. Simply antigen, there will be any infection, antigen will be there. Okay, then antibodies will be released. It will make what inflammatory responses. Okay, when there is an inflammatory responses, leukocytes will come into action, which is WBC. The WBC come into action. Okay, when the WBC will be coming into these glomerulus, it will thicken the glomerulus. Okay, it will thicken the glomerular filtration membrane. We have the GFR, right? Glomerular filtration membrane. It will thicken the glomerular filtration membrane. When the glomerular filtration member is thickened, what happens? The functions. Okay, usually this is the thickening. If antigen antibody reactions occur and the WBCs come here, the membrane will be thickened. So what happens when the membrane is thickened? The amount of some substances filtered will be decreased, right? So decreased GFR. When there is decreased GFR, the sodium and water will be retention, and you may have edema and hypertension. Okay, so this is the pathophysiology of glomerulonephritis. Simply understand like this: antigen antibody reaction. What is an antigen? It may be any pathogens. Okay. Any antigen will come and an antibody will be responding. When there is an antigen antibody reaction, when there is an antigen antibody reaction, it leads to WBC formation. It will thicken the glomerular filtration membrane. When there is a thickening, the glomerular filtration rate will be decreased. Thus, retention of sodium and water will leads to edema and hypertension. Okay. So glomerular filtration, glomerulonephritis. What is glomerulonephritis? It's an inflammation of the glomeruli. Okay. Any itis. Itis means any itis means itis. Yes.
Infection.
Yes. Any doubt? Any itis means it is an infection. Okay. So glomerulitis, glomerulonephritis. Nephritis means kidney. Glomerulus means the glomerulus which is present in the nephrons. So any inflammation to these glomeruli will leads to. Okay, that is glomerulonephritis. We have primary and secondary glomerulonephritis. So primary means it is starting from the glomeruli itself. Okay, secondary means glomerulus are affected because of systemic diseases. Okay, any other diseases, that is secondary. And we have acute glomerulonephritis and chronic glomerulonephritis. So the name itself indicates if there is any sudden effect. Sudden effect, then it leads to an acute case. Sorry, when there is a sudden, when there is a sudden effect, it will leads to an acute case, or when the disease is not treated, or when the disease is developing very slowly, or irreversible failures, then it may cause to chronic glomerulonephritis, right? And what are the causes of the chronic glomerulonephritis? It is mainly a non-infectious, or it can be infectious. Infectious conditions, UTI may be a reason. Non-infectious means if there is an anaphylactic shock, there may be an antigen. If there is an aseptic shock, there may be an antigen. Or if there is any changes in the basic hormonal effects, it may be a non-infectious causes. Okay. So bacteria, the basic bacteria is what we are talking about in the infectious cases. What is the case of chronic glomerulonephritis? See, in case of chronic glomerulonephritis, the infection may be from other sites. It won't be from the kidneys. It will be from the other sites, like bacterial infections in the lung. See, in the lung disorders, systemic lupus erythematosus, Goodpaster syndrome. All these things can lead to the chronic glomerulonephritis. Can anyone in the class say what is Goodpaster syndrome? Anybody? See, Goodpaster syndrome is nothing but an autoimmune disease that affects the lungs and the kidneys. Okay. It's an autoimmune disease. It's an autodestructive disease. Okay. It is affecting the lungs as well as the kidneys. Like polyarthritis, arthritis, right? So multiple arthritis will be the polyarthritis. It's just a minute. Yeah. So that was about the chronic glomerulonephritis causes. First one is a bacterial. Okay. Second one may be a autoimmune diseases, or it may be from the lung disorders, or your diabetic kidney diseases. Okay. It may leads to a chronic glomerulonephritis. Like, what is the changes in the acute glomerulonephritis? The main symptom is hematuria. See, when you just first thing you just understand what the disease condition is, right? Then you can relate with that. Okay, if there is a glomerulonephritis, it is an infectious condition. It is affecting the glomerular filtrations. Okay, if there is infection, in case of any infection which is affecting the kidney, bleeding may be a reason. Then, if the glomerular filtration is affected, I have already said it may be tampering with the filtration system. So protein will be present in that. The urine will be decreased because of the decreased GFR. Hypertension, I have explained why there is a hypertension. Okay. Edema, when there is edema, the edema have to be anywhere. Like it may be ascites, it may be pleural effusion, and it can be any other areas. In case of chronic glomerulonephritis, so it is chronic condition, it is there for a longer time. The patient will be anemic. Hypertension will be there. Severe proteinuria. Because of proteinuria, protein is wasted from through the urine. There will be weight loss. So, protein is a substance which is causing you the weight gain. So when protein is not present in the blood or when it is washed through the urine, it leads to weight loss. Generalized edema. Why? Because of sodium and water retention. That's why they can have a hypertension also. Dyspnea because ascites may be the. What are the clinical manifestations? Pain, frothy urine. I have said foamy or frothy urine because of protein present. Albumin is present in that. Cola colored urine or tea colored urine in case of glomerulonephritis, hematuria, oliguria, dysuria. Okay, anemia because of kidney failure, hypertension, fluid retention. I have explained all these conditions why it is happening. You have just to connect that. You just connect it. Then see hematuria. Uh, it may be because of kidney problem. Okay. So why hematuria? Just take the screenshot. Okay. Why hematuria is happening? It may be because of the problem with the kidneys, pyelonephritis, renal masses, necrosis, PCOD. Sorry, not okay. Ovary disease, kidney disease, polycystic kidney disease, PCKDs, polycystic kidney diseases. Then AV malformations. Then if it is in the ureter, basically the stone is the reason. Malignancy, strictures, any polyps present. In the bladder, there will be cystitis, malignancy, or the radiations. In other conditions like benign prostate hyperplasias, then prostate cancers. If you are doing and severe exercises and your muscles have been wasted, pseudo hematuria will be there. Okay, that is orange colored urine. Okay, then complications like it may affect the acute or chronic renal failures, nephrotic syndrome, electrolyte imbalances. You know why pulmonary edema happens. You know why heart is having an overload, fluid overload will be there. No, proteinuria and hematuria. In case of urine analysis, when you do the urine analysis of glomerulonephritis, you can see proteinuria and hematuria. So what will we do? We'll take a needle biopsy. We'll take a CT to properly understand the condition. Management, diuretics, immunosuppressants. Why immunosuppressants? We don't know what is the reason of the antigen that is coming into action. In that condition, to prevent the antigen antibody reaction, we will give immunosuppressants. Okay. See, here in immunosuppressants, when I'm talking about immunosuppressants, there are a lot of rare diseases that is affecting or that is causing these immunosuppressants. We have to check into that. But for your prometric examination, nothing will be asked from there. Okay, it is too complicated for the prometrics. That's why I'm leaving it. Okay, monitor the fluid and electrolyte balance, metabolic rate, pulmonary functions, infection, skin care, and support. All these things are the nursing management. Next disease condition is bladder cancer. So you know the bladder how it is. This is the bladder and the bladder tumor which is present. Now, what are the reasons for that? What are the reasons? Any chemical exposures, okay, during work. Arsenic water when you're drinking arsenic water. Lifestyle, smoking, alcoholism. If there is a genetic predisposition of cancer in the family, chronic bladder infections, like come uh, usually when the patient is getting infected with urinary tracts, any medications. Okay. Uh, Now, just take the screenshot. The main signs and symptoms of bladder cancer. These are the main signs and symptoms of bladder cancer. Urine will be pink in color, or red in color, or cola colored. Ashwati, are you present in the class? Yes, Ashwati is there. Vino is there. Kavya, are you present? Kavya? Kavya? No, Kavya is not here. Lenu? No, Lenu is not here. Monisha? Pratibha? Yes, Pratibha is there. Priyanka? Are you
Yes,
there
sir.
in the class?
Yes,
Okay.
sir.
Rajesh is there. Rajeshwari is there. Then Rajeshwari's husband Ranjit is also there. Sangeeta, are you there in the class? No. What about Satyapriya? Sophie, are you there?
Yes, sir.
Okay. Soumya is also there. Okay, fine. Uh, So the symptoms include urine discoloration. So bladder cancer, it is not mandatory that the urine should be a color. The urine should be pink or red in color. Okay, and your peeing habits have been changed. That is what you have to check. You will ask the patient about the micturition status of the patient. Okay, the patient will be more often going into the washroom. The patient may feel pain during micturition. So patient may feel urgency. Now I have to go. The urgency will be there. And when you go into the washroom, but there won't be any urine. Why the urgency is because the urinary bladder is having something apart from the urine. So that is the tumor. That tumor will give you the urgency of going into washroom. Okay. And there will be one-sided back pain. Okay. And weight loss. Okay. Without trying. If you are dieting, you may go for a weight loss. But you are doing nothing, but your weight is losing. You losing your weight. Okay. So those are the you will be very fragile. You will be very fatigued all the time. Next, the effect of the bladder. See, you can see this is a bladder lining. This is a connective tissue that is affecting muscles as well as the fat. So in the stage one, it will be somewhere around here. In the stage one, it will be somewhere around here. In the stage two, see, it have covered the bladder lining and it is touching the connective tissues. In the stage three, it is touching the muscular tissue. And at the stage four, it have covered the fat tissues and it have started metastasizing. Okay, now it may affect the other portions also, metastatic bladder cancers. So there are the four stages of bladder cancers. Now, TNM, just take the screenshot of this. This is what we were explaining in case of lung cancers. Just take the screenshot. This question may be come. See, TX means tumor cannot be accessed, and NX lymph node. No lymph node can be accessed. M0 no metastasis. Now T0. T0 means no evidence of primary tumor. We can't identify any primary tumor. N0 means no nodes are involved. Okay. M0, then there is no metastasis. Okay. Then TA, papillary non-invasive tumors. Papillary non-invasive means it's just uh, in the cellular stage itself. Okay, that is an early detection. So if you are early detecting that condition, that is very easy for you to treat the thing. Okay, TA. Next is TIS. So carcinoma in situ. In situ means it is for example, if it is bladder cancer, the cancer is present in the bladder itself. Okay, it's just in the bladder. If it is breast cancer, it is just present in the breast itself. Lung cancer, it is just present in that area. So the tumor which will be just present in that specific area. Okay, that is in situ. Then 1, 2, 3, 4. 1, 2, 3, 4 means it depends upon the inversions, how deep it is inverted. Usually a T1, T2, T3 and 4, for the basic understanding, you can understand like that. T1, it have affected the connective tissue. T2, it have affected the muscular tissue. T3, more deep into that, it have affected the organ itself. T4, it have started inverting to adjacent organs. Okay, through its perinephric fat and also. Likewise, the regional lymph nodes 1, 2, 3, single node, which is of 2 centimeter or less, N1, N2 means multiple nodes, N3, multiple nodes with more than 5 centimeters of dilations. Metastasis, M1 means there is a distant metastasis. Okay, so hope this is clear with you. And what are the main common bladder surgery management? First one is surgery, we just remove it. Now, here is also a catch. Questions may come from here. There are the bladder. See, what happens is that we'll remove the entire bladder. Okay, in this condition, we'll remove the entire bladder and a new bladder will be replaced. Like uh, couch pouch, Indiana pouch, all these are the extra pouches that we'll keep. So simply we are not keeping a plastic bag and keeping the body's perinephric fats and all these things will be surgically modified, and we'll keep it in the areas of the bladder so that it acts as a bladder. Okay, one condition. Next condition is these ureters. Okay, the ureters will be connected as a one, and we'll connect this ureter to your ileum or the small intestine, so that the patient won't pee now. The patient have to what you have to defecate the urine. So the patient will be having the urgency to defecate in 3 or 4 times per day. Fine. Third one, a third one, we'll just take this and we'll connect it to the outer surface of the stomach. We'll make an ostomy on the abdominal area and we'll remove from the. Fine. So this that was a catch here. Next, immunotherapy. You know, immunotherapy, chemotherapy, targeted therapies, all these things are chemotherapeutic substances. Modern radical cystectomy. Modern radical cystectomy means we'll remove the removal of bladder with surrounding fat so that it cannot infiltrate to the through the perinephric fat and affect the other portions of the body. In case of males, we'll remove the prostate as well as the seminal vesicles so that the seminal vesicles are moving and it is taking these ejaculatory response to some other parts of the body. So to prevent that, we'll just remove the prostate. Prostate is also a uh, like prostate is a cancerous no, prostate may leads to a cancerous condition also, because benign prostate hyperplasia is a condition. So to in order to prevent that, so ureters and the fallopian tubes, ovaries, cervix will also be removed in case of females, because it may be affected, because all these things are very adjacent nearby. Okay, then pelvic lymphadenectomy. So we'll remove the lymph nodes which is there in the pelvis, because there might be a chance of infiltration to the lymph nodes. Okay, then that is the third one is urinary diversion. The bladder is removed. The bladder have to be taken to any other portions. So first condition is ileal conduit. So that is what I have said. We'll connect it to the ileum. Okay, then we'll make the reservoirs. What are reservoirs? Pouch, Indiana pouch, all these things are the reservoirs. Now, orthopedic neobladders, we'll remove with other bladders like that. Okay, see, ileal conduit and it can be taken out. It's a stoma which is opening into the bladder. Okay, this is the ileum. It can be taken into the ileum. So, if other portions are taken, which means if the bladder is not connected to, or the ureters when are non connected to the intestine, we can take the some portion of the intestine and we'll make it a tube-like structure, and it will be taken out as a stoma portion. Okay, continuate reservoirs like this. Reservoirs can be made. See all these things. See, usually questions will never come from this, but in case these are important topics, that's why I'm just taking it. In case the prometric may ask, So you don't need to understand the procedure. You don't need to understand how it is fixed and nothing like that. Just understand the name. Coach pouch. See, Indiana pouch. Next is ureterostomy. Opening is done. Okay. An opening is done and the stomas are kept like this. See, you can see the picture itself is self-evident. Nephrostomy. The urine will be directly collected from the kidneys. Okay, when the if you have to remove the ureter also, the nephrostomy will be done. Now, a BCG therapy is given for the cancer, the bladder cancer. How it is done is that we'll just like this picture. We'll infiltrate the catheter. We'll place a catheter into the urinary bladder and we'll inject the BCG injection to it's simple. The Bacillus calmette and guarin, the same thing. TB medicine. This is also act as a cancer treatment also, or the urinary TB bladder. Okay, if it is the bladder is affected with TB, a catheter is passed, then we'll insert the medicine into the bladder and we'll ask the patient to hold the urine which is present in the bladder for at least for half an hour so that it can act. After that, we insist the patient to use a washroom and what urinate. After urination, the main management is you have to make sure that that bathroom is thoroughly cleansed before the next patient is using. Okay. Now, BPH, benign prostate hyperplasia. So, the benign prostate hyperplasia, it is only seen in males. This is a normal prostate when there is a hyperplasia. Usually, benign prostate hyperplasia is a non metastatic cancer. Okay, it's a benign cancer. What are the risk factors? Age, family history, diabetes, food. Age is the main condition. Okay, we don't know what is the reason. Any endocrinological factor might be there. Okay, obesity, inflammation, or alcohol consumption may lead to BPH. What is the main problem? You know, this is the area which you have to pee. This is the prostate gland. So when the prostate gland increases its size, what happens? It will compress the urethra, right? So when the urethra is compressed, what are the symptoms that the patient shows? The patient starts difficulty in peeing, straining to pee. Okay, they have to uh, urge pressure into that. The flow of the urine, it will be weak. Stop. When you pee, you have to, or it will automatically stop. Then you have to pressure. Then again you have to start. Then stop. Then start. See, this is the symptoms that occur. And needing to pee, urgency. There will be an increased urgency. Frequency will also be there. Urinary incontinence also will be there because the bladder won't be cleansed properly. It won't be emptied properly. Some sort of fluid. The resident fluid will be, or the resident urine will be there. Residential urine will be there, or the residual urine will be there. What are the complications? If there is increased water or the fluid inside the urine inside this, it may leads to muscular hypertrophy. Trabeculation will be there. Diverticula will be there. Okay, it will compress urethra, and there is a reverse flow, reverse backing of the urine. Urine may go back. See, this is happens when you lie down. Okay, when you sleep. So reverse bladder hydronephrosis will be there, which also need to this ureters will be hydroureters will be the hydronephrosis will be the this hydro means urine will be reverted back to the kidneys. Okay, which will leads to obstructive uropathy. The condition we have said what is affected with the kidney. When the kidneys are affected, we have renal causes, extra renal causes, and post renal causes. In that, we have studied BPH is a complication. BPH is a condition. So, the obstructive uropathy can be occurred on urolithiasis. Okay, just take the screenshot, guys. These are the main BPH complications. You just have to understand like this. If it is compressing the ureters, no, the urethra, what happens? What happens to the fluid in that? The urine in that? per rectal examination. That is how it can be diagnosed. And a nurse or a doctor inserts a finger through the rectal, and when you press upward, you can feel a steadiness. Usually, it should be soft. You can feel a steadiness. Okay, and there are grade 1, grade 2, grade 3, and grade 4 prostatomegaly. If it is grade 3 to grade 4, you will be feeling that how you are touching a wooden table. Okay, that much hard it will be. Then it is diagnosed on the basis of ultrasound. If BPH is diagnosed, you'll go for the surgery TURP, transurethral resection of prostate. Okay. And there is a blood test which is known as specifically prostate specific antigen. This one, prostate specific antigen. The PSA will be elevated. Okay. If those two conditions are clear, and if it is affecting the activities, or if it is so complicated, we'll go for the surgery. Okay. So stage 1, 2, 3, 4. In stage 1 and 2, there will be significant obstruction will be there, and bothering symptoms. Okay, bothering symptoms will be less. So we have to watch and counsel. The bothering system is there. We'll go for medical treatment. What is that? Smooth muscle relaxants. We'll give Urimax. Okay, Urimax is a drug of choice. Tamsulosin. The name is Tamsulosin. The medicine is Tamsulosin. So we'll give the Tamsulosin to the patient. And the third one, in the third stage, the obstruction will be present, and the symptoms, it will be the patient will be having severe symptoms. So we'll go for surgical options. We'll go for cystoscopy, and we'll visualize that and all those things. In stage 4, definitely you have to go for the surgery. Okay. TURP, TURP, transurethral resection of prostate. We'll insert a catheter, we'll insert the cystoscope, and then instrument into that, and we'll remove the prostate. Okay. See, this is our how an enlarged prostate is removed. Fine. Now, what are the complications of the surgery? Yes, just a minute. The complications of TERP, the main complications of TERP, immediate complications after the surgery. The main immediate complication after the surgery is bleeding will be there, and a TUR syndrome, transurethral syndromes will be there. So the syndromes, see, there are a lot of syndromes in that. Like if the surgery is done after the surgery, after the TURP surgery, or during the TURP surgery, you have to check for the surgery will only last for 45 minutes. Okay, we won't cross the time of 45 minutes for the stress surgery. Why? Because we are doing the transurethral surgery with the help of a 3 liter. I don't believe you would have seen that 3 liter NS or a 5 liter NS are coming. Okay, so we'll keep that NS, and we'll irrigate throughout the surgery. Why? Because there will be bleeding, right? So when the transurethral surgeries are done with these ureteroscopes, there will be some pouches. The pouches will be opened during the surgeries. Okay. And when we are irrigating with the saline, there is high chance of the fluid, the saline will be uptaken by these pouches, and it will dilute the circulation. Okay, the blood will be diluted. The proper blood is leaked, right? So in that area, from through that leaking, the sodium will be, or the saline will be absorbed. When the saline is absorbed into the bloodstream, it will dilute the blood. Okay. See, it is not like when we are giving 1 pint of fluid or 2 pint of fluid. What is the reason? There is a therapeutic indication for the patients which we are giving the fluid therapy. But this patient is not having any therapeutic indication. Instead of that, the blood is losing from the body, and via the blood, the saline is uptaken by the body, which leads to dilutional effect. So when we cross it more than 45 minutes, these dilution may be increased, and the patient may go for collapse. or the it leads to dilutional hyponatremia, and lot of complications are there. Okay, so the surgeon who is doing is that will be very keen on the time, and they'll anyhow will uh, will uh, complete the surgery within 30 to 35 minutes. Okay, so 45 with a cut shot. Then the late complications, there will be urethral strictures, tying of the urethra will be there, bladder neck contractions will be there, retrograde ejaculation. What is retrograde ejaculation? So instead of ejaculating out, okay, the ejaculation, the semen will be ejaculated in the urinary bladder. Okay, that is retrograde ejaculation. In some conditions, there will be impotency also. See, impotency and retrograde ejaculations are not as seen. Why? Because all these patients will be of 60 plus age, and they'll be usually having children as well as grandchildren. So impotency won't be an issue. And the sexual functions may not be so active in such people who will be having a multi-organ disorders. Okay. Anyhow, it's a problem. Those are the late complications. Now, see what you have to check. Catheter should be maintained. Patency. So after surgery, see this is the 3 liter. This is a 3 liter saline. Okay. After surgery, you have to place the patient in the post-operative area, and the 3 liters of uh, saline should be irrigated to the patient. So this is a catheter which is having a three-way opening. Okay, three-way catheters. In one catheter, the saline, the normal saline will be flushed. One will be collecting the urine, and one to infiltrate the bulb of the catheter. So this is a three-way catheter. So there will be a continuous irrigation into the bladder. Why we'll be giving a continuous irrigation to the bladder? Because we need a clear urine. Usually for the first 24 hours, there will be hematuria, and you have to check the CBC after 1 year, 1 day. Okay, you have to check what is the status of hemoglobin blood loss. Until and unless the urine become clear, we won't stop the normal saline. See, there is high chance of formation of clot. When the clots are formed inside the bladder again, we have to do the surgery again, so that we have to remove the entire clot from the bladder. So in order to prevent that, continuous irrigation is given. Okay. And the main complications are hemorrhage, which we have said. Okay, so the bleeding should be decreased to light pink in 24 hours, which means after 24 hours, the urine be clear. You have to, if there is an urinary incontinence, Kegel exercise will be given. Infections to infection will be there, so you have to increase the fluid. Deep vein thrombosis, because the patient is on the bed itself. Okay, to have to prevent, and compression strokings can be given. So these were the diseases which majorly come from the renal genitourinary nursing. Guys, are you having any doubt in any of the topics which we have dealt till now?